So without further ado, I'm really excited to introduce our next speaker, Dr. Jennifer Salant. Dr. Salant is a pediatric intensivist and director of the Pediatric Advanced Care Team at Weill Cornell. She's triple board certified in pediatrics, pediatric critical care, and hospice and palliative medicine. I think she might be our first triple boarded person that I've introduced this conference. So go, Jennifer. After med school at Cornell, she trained at CHOP, Columbia, and Memorial Sloan Kettering for pediatrics, critical care, and palliative medicine. Then she returned to Weill Cornell as faculty. Dr. Salant is a dedicated educator, teaching both clinical skills and serious illness communication through Vital Talk. Thank you so much for joining us this morning.
Oh, thank you so much for having me, Dr. Bewald. It's nice to see you. And thank you for having me at this course. I've done this for a couple of years, and I'm really happy to provide guidance on high-yield topics in pediatric palliative care for the HPM exam. So I have no conflicts of interest, unfortunately, and I also have no knowledge of the questions on the HPM board exam, but I took the exam, and so I anticipate we're going to talk about topics that I think you're going to see along the way. So what are my objectives in this talk? I'm going to provide an overview of pediatric palliative care, some of the definitions and key principles, some pediatric epidemiology, and then some special considerations like the cases of neonates and adolescents, because these are special populations that we need to think a little bit more about when we provide palliative care. I'm going to briefly touch on pediatric pain and symptom management. Briefly discuss pediatric communication and decision-making. That sort of includes the developmental understanding of grief and death. That's a very high-yield topic, as well as pediatric advanced care planning. How do we do it? I'm going to talk about pediatric hospice and this idea of concurrent care. And then finally, ethics and legal issues that you may encounter in pediatrics. And all throughout the lecture, we're going to go through some practice questions and answers together. But when it comes to the test itself, so just some general tips. According to the ABIM blueprint, approximately 10% of the exam is pediatrics, and that will include perinatal conditions and infant death, genetic and congenital conditions, other pediatric conditions, needs of bereaved minor children, and pediatric decision-making. This is what the ABM lists, okay? But I want to be clear that while children are not little adults, which is like a famous phrase that we say in pediatrics, the principles of palliative care are similar for children and adults, right? We deliver palliative care alongside disease-directed therapy. We relieve multidimensional pain and suffering. We, care about communication and goal concordant care, and bereavement is a part of our practice. So even though 10% of the exam is pediatrics, often the questions are testing a principle of palliative care. They're just using a pediatric case. And so when in doubt, just rely on your principles of palliative care. They're the same. You just need to approach them in the same kind of way. You probably know the answer. Okay, let's talk about pediatric palliative care. What's the definition? I don't have to make it up because the World Health Organization says what it is for me. It's aimed at optimizing quality of life and mitigating suffering and serious illness. And it's the active total care of the child's mind and body and spirit. It requires, by definition, an interdisciplinary approach. It's appropriate at any age or any stage of illness. It includes the family and utilizes community resources, can be provided alongside treatment intended to cure or prolong life. And similar to palliative care in general, it's based on need and not prognosis. So then what's different in pediatrics? So first of all, many children affected by pediatric diseases don't survive into adulthood. So what this means is that we're often dealing with a different set of conditions that often have different trajectories or different natural histories than maybe we're used to in the adult world. Mortality in children is very, very rare, and less than 1% of deaths occur before age 20. But let me just say that when we look at the majority of pediatric deaths more commonly occur in the younger ages. Obviously can happen at any age. And we're also dealing with congenital, genetic, and metabolic conditions. So some different conditions than maybe we're used to seeing in the adult world. Prognostication is very difficult in pediatrics. Prognosis is often less clear, especially in rare disorders. If we have a genetic disorder that there have only been a handful of children with, it's really difficult to prognosticate, right? And so I remember when I was taking the boards, there were all these ways of prognosticating heart failure and, neurologic disorders. And I remember having to go through dementia. This is different in pediatrics. It's much more difficult. So we're often not able to give really pinpointed prognoses. And so we have to make room for the uncertainty in pediatrics. Some disorders affect multiple family members, like siblings. So sometimes we're providing palliative care and goal concordant care for multiple siblings at once, or we're dealing with a family that already had a child die of the same condition, and they're coming to you with new lessons or with experiences that we have to take into account. I've had situations where a family, wanted to approach end of life differently for the second child with the same condition because of an experience they had with the first child. Children are increasingly living with the help of medical technology like tracheostomy, enteral tubes, et cetera, right? So this idea that, when we're doing decisions about tracheostomy and other medical technology, sometimes, this can actually help a child live for decades and can really play a role in providing a quality of life for them in addition to length of life. And so the calculation surrounding things like tracheostomy, enteral tubes, et cetera, is a little different. And care is delivered in the context of child development. Children can and should be participants, which is to say, in their care at their developmental level. We do engage children to help make medical decisions at the right developmental level, while also considering the family preferences. Okay, so board style question number 1, I'm just going to read it. A 2-month-old male with a life-limiting condition is receiving end-of-life care at home with hospice involvement. On exam, he has a clenched jaw and a quivering chin, is intermittently back arching and kicking his legs. His mother tells you he's been crying for the past 60 minutes and he's not been redirectable by his parents or other stimulation. Which of the following interventions is most appropriate for managing this infant? Okay, so 2-year-old male at home showing these showing these signs. So do you administer a dose of morphine, administer a dose of a non-steroidal anti-inflammatory, start a sedative and increase the dose until he falls asleep peacefully, or do not administer any medications because infants do not feel pain under 6 months of life? So I'm hopeful that you all can recognize that this is a child who is in pain, and pain can look a little different for babies. We don't want to give an NSAID. He's a little young for an NSAID. We typically don't give it younger at the age of 2 months. Starting a sedative and increasing the dose until he falls asleep is really not the answer ever in this case, really in these cases. And then this idea that infants don't feel pain under 6 months of life is an antiquated thought. Even premature neonates can experience pain, and we want to be active and treat it. Okay. So really, this is a question that's getting into the idea of pain scales in pediatrics. So how do we assess pain? So I'm sure you're familiar with the numeric pain scale. I'm sure you ask this to your patients. For children who are 7 and older, typically, and verbal, typically we'll say, on a scale of 0 to 10, with 0 being no pain, 10 being the worst possible, what is your pain? And we ask that question. There's also the FACES pain scale, where it's a picture-based scale. We say, these are different examples of pain. Point to the one that you're feeling right now, and they can give it to us in pictures. There's the pain word scale, right? For even younger kids, are you feeling it a little, medium, a lot? It's a little more descriptive. And then there's the FLAC scale, and that's what this question was getting at. From 2 months to 7 years, or nonverbal children or cognitively impaired children, there's a series of 5 behavior items regarding its face, the patient's face, legs, activity, cry, and consolability. And each of those are worth 2 points. And this patient that I had described met, criteria for severe, which would be 7 out of those 10 points at least. just acknowledging that we can assess pain in nonverbal children and even in infants, and we use that scale. Okay. Board style question number 2. You're a hospice physician caring for a 36-year-old woman with metastatic breast cancer. And at her most recent visit with you, she and her partner request guidance on how to discuss her illness and eventual death with their 7-year-old daughter, who is currently in 2nd grade. Of the following, which is the most appropriate step to facilitate the discussion? Okay, so it's an adult patient, but a pediatric question. A, advise the parents to avoid discussing death due to the child's age. B, recommend waiting until the child initiates the conversation about death. C, encourage the parents to use simple and honest language addressing the topic when the child has questions. Or D, arrange for a child psychologist to have this conversation with the child. So I actually, I wrote this question, but I think this is actually kind of a hard question because I can imagine sort of rationalizing some of these answers. But the answer here is definitely C, this idea to use simple and honest language addressing the topic when the child has questions. We really recommend speaking to children directly about illness and death, avoiding euphemisms, which I'm going to get to, and really addressing the topic when they have questions. There may be times where we want to engage a child psychologist if there are other sort of concerning features, like if the child is having some behavioral concerns or if they have a history of mental health, struggles, et cetera. But there is really, at this age, we would not recommend avoiding discussing death due to the child's age. Okay. So really what I want to spend the next few minutes about is talking about how children sort of begin to understand the concept of death in the context of their development. This is a very high yield topic. I imagine you're going to see questions about this. And also, if you're going to take care of adults, you're going to take care of their children in one way or another. So this topic is going to come up. There are 4 concepts of death that children sort of reach and, begin to embrace as they develop and reach new cognitive milestones. The first is the irreversibility of death, that death is unfortunately a one-way process, and that once someone dies, they don't come back. So we're going to talk a little bit about this, but if a child sort of thinks about it in terms of going to sleep and waking up, that's a child that's still learning the irreversibility part of death. Finality, which really means non-functionality, that the body's processes stop when someone dies. So I've heard examples of children who have, understood that a family member has died and they're at the funeral and they say something like, do we need to, bury them with a snack in case they get hungry, right? That's a child that's still learning the concept of finality, non-functionality, causality, the things that cause death and the things that don't cause death. Children go through a period of magical thinking, which is, where their imagination and reality sometimes blend. It's a normal developmental milestone, but what it can do is make children sort of wonder if they caused the death by thinking something. And so we spend some time counseling children about, that this isn't something that they caused. And then finally, the universality or inevitability that we all die, that none of us are immune. And that's a stage that comes a little later. Even some adults, young adults and older adults, I think, struggle with this concept as well. The concept of death changes as a child develops and acquires cognitive milestones, acknowledging that not every child reaches these milestones at the same time. And I'll also mention that the American Academy of Pediatrics has recently liberalized the developmental milestones, that there's even more variability than in reaching these milestones than we had previously thought. Children with developmental disabilities may follow a different path. I don't think you'll get really intense questions about that, but just acknowledging that we may need to have a different approach for a child with an intellectual disability. The first experience of death may be with a pet. And this is actually something that I counsel about with my families, that when a pet dies, it's actually a really good opportunity to practice the skills of talking about death in a concrete way, without any euphemisms like they went to a farm farm or they're going on a trip, and really try to get that experience talking to children and seeing how they do with it. I'm going to do like the whirlwind, like developmental milestones in terms of death and thinking of death, things that I think you might get asked about. Just acknowledging that like you can spend years talking about this. So we're just going to do like broad strokes. So in ages 0 to 2, right? Okay, so like lots of stuff happening between 0 and 2. But the big sort of takeaway here is that usually children under the age of 2 really can't understand the concept of death. There are precocious 2-year-olds that might be able to sort of scratch the surface a little bit, but typically, their language and cognitive milestones are fairly limited, although some 2-year-olds can be pretty verbal, but they really don't have a concept of death. It's really hard to have this discussion with them, but they can perceive emotional changes in others. And so the emphasis in this small group is going to be maintaining routine, because when routine is disrupted in this group, that's when things get really, really challenging. Ages 3 to 5, the preschool age. These are children that are, as I said, have magical thinking. Their imaginative world is sort of like blending with their real world. This is normal. This is part of the creative developmental process. They often consider death as temporary, or a form of sleep, or contagious. That's like a very common thing. They may ask questions repeatedly. I wish I had time to show one of my favorite clips from Sesame Street from when I was really young. It actually might have even been out before I was born. But there was an example of like Big Bird learning about the death of another cast member, and they kind of ask the question over and over again. And it's a really good example of what a typical 4-year-old might ask, when is so-and-so coming back? When am I going to see them? Totally appropriate for a 4-year-old. So we talk about concrete explanations, avoiding euphemisms. That's like the big one. Repetition. This is a conversation that you may need to have many times to get the point across. It's okay. It's expected. And then play therapy, right? These children might have language skills, but maybe don't have the language to express how they're feeling in a nuanced way. And so that's where we use art therapy and music therapy and bibliotherapy, et cetera. Ages 6 to 8, the young school age, they're learning cause and effect, right? That's sort of like one of the things that they're learning. And so they may consider death as temporary or a form of sleep or contagious, like the younger kids. And they might ask questions about responsibility. Why did this happen? Who, is it going to happen to me? Is it going to happen to someone else I know? So again, similar things here, concrete explanations, avoiding euphemisms, and repetition. For the older kids, like middle school age-ish, they typically understand cause and effect. They're really learning their critical thinking skills. So they typically understand the physical aspects of death, but less so the spiritual or existential aspects of it. So I typically will approach these, I would counsel these families to start by asking them what they understand. And actually, I would say that in all these age groups, like we would with any serious illness communication. What is your understanding? Tell me, what do you think is going on? And it's okay to be open to say, I don't know, if they start to ask existential questions when applicable, right? We don't have to make up things that we don't know the answers to. It's okay to say, I don't know. It's also okay, I didn't explicitly say this, but it's also really okay to normalize the emotions of grief. We are all sad. I'm sad too. You're not alone in feeling this way, because just normalizing that this is a really diverse emotional experience, and that there's no one way to feel. And then finally, in the adolescence, establishing autonomy, learning abstract thinking. They typically understand the finality of death, but maybe considering the spiritual aspects of it. They also often have sort of more adult concerns like financial concerns. Who's going to take care of my siblings? That might weigh on them. They have a higher chance of risk-taking behavior because some of them are driving, some of them have access to buying things and, behavioral risk-taking behaviors. So what we typically encourage is discussion with peers when appropriate, getting the teachers involved, letting them know, giving them a role in decision making when appropriate, and respecting that choice. That's really important. In general, I think, is if you're going to offer a child a choice, which I would recommend if you're able to, because it gives them a sense of autonomy in a situation that feels out of control, you got to respect that choice. And so that's often helpful. And it gives them, and also giving them a role, something to do, in certain circumstances, like, a role at a funeral or a role in some other aspect, to give them a sense of autonomy when things feel really out of control. So some high yield tips when discussing death with a child. These are the things I think you might come across on the boards and in life. Assess their understanding first. Ask and then listen, right? This is good with, I think, like I said, any serious illness communication with any age, but especially with children. Also, similar with serious illness communication with adults, anticipate their emotion, their anxieties and their fears. Anticipate it. It's there. And be ready to address it and normalize it and respect it, and all of those ways that you are so skilled at supporting. Utilize your interdisciplinary team. If you have the luxury of child life therapy or a chaplain with experience with children or social work, other creative arts therapies, etc., utilize them. The hospital may have access to them. At least at Cornell, an adult team can call the child life consult to help with some of these things. And so think about what your support may be and use them. Be truthful. This is really important. Children know when we're avoiding talking about something. I'm not even talking really right here about talking to children about their own mortality or talking to children about their own diseases, but they know when we're not sharing the whole truth. They can sense it, and often it's more anxiety provoking not to have the conversation than to just have it with them. Avoid euphemisms. I cannot stress this enough. If you're going to take, one pearl from this section of my talk, please, please, please avoid euphemisms in speaking with children. Sometimes you need to divide the information into manageable amounts. You can't do the whole conversation in one sitting like you might be able to with an older, adult. Like I said, consider alternative communications. Confirm their understanding throughout the conversation. And like I said, considering the cultural, religious, spiritual factors that play a role here. And if you give a choice, you got to honor it. The child is in control. Don't forget, siblings are also mourners, right? And so if you're in a situation of surviving siblings, we have to think about them. And also acknowledging that losing a child should really be a never event, honestly. And so some people will even say that any pediatric loss is a setup for complicated grief, because it really is not part of the natural history of how life should be. And it feels very different. And so just acknowledging that this might have a different kind of trajectory in terms of grief. Speaking to children about their own mortality, I could give a whole lecture, a whole course on this. So I'm going to touch upon the biggest points. Well, first I'm going to share this study that there was a retrospective, and I'm bringing this up because I feel like the boards just loves this study. I feel like it came up over and over again in my studying. There was a retrospective study that looked at interviews with parents in Sweden who lost children to cancer in the mid to late 90s. And of the 449 respondents, 147 of those parents spoke to their child about death, and 269 parents did not speak to their children about death. And the takeaway here is that 0% of families who spoke to their child about their own upcoming mortality expressed regret for having that discussion. And yet 27% of families who did not speak to their child about death did later on express regret. Parents who sensed that the child was aware of their imminent death, which I think happens more often than not, is more likely to regret not speaking about it. And so I think this is just one study. It's an older study, but what this really gets to the heart of is that we can and should speak to children about their own mortality. It is, I think, relieves anxiety that the children may have, and really can actually help them ground themselves. I think if you do it in a skillful way, which I really don't know if the boards are going to get into the details of all of this, but I do think that the theme of speaking to children directly should happen if the parents are open to it, and that families typically don't regret having these discussions. So I just want you to file this away because it really gets to the philosophy of engaging children in their own discussions when appropriate. Children also reach spiritual milestones. Like their 4-year-old has an active spiritual life. It's just the active spiritual life of a 4-year-old. They have existential distress. It's just existential distress at the level of a 4-year-old. So we address it. We address it like we would with anyone. And I just want you to be aware that pediatric advanced care planning is a thing. Like I said, children usually know something is wrong. Children can participate in advanced care planning at the age appropriate level. They have cultural, religious, and spiritual considerations that we need to consider, obviously, and to utilize, like I said, your interdisciplinary team. So I'm sure you know about 5 Wishes. 5 Wishes is, advanced care planning for adults. In many states, it becomes a legal document when you fill out the 5 Wishes, I think. I don't really do a ton of adult work, but so in children, when we go through these advanced care planning tools, we have Voicing My Choices, which is amazing, and I use it in almost all the time. In most contexts, it sort of goes through advanced care planning things with children, with adolescents and young adults at a really beautiful, age-appropriate way. I think it's good for any adult too. And then there's a concept of the tool of My Wishes, which is a little bit younger. Some of the questions that these tools ask are like, do you like being touched? Do you prefer like to not be touched? Do you like, like what I mean is like physical touch when you're feeling like, do you like hugging and stuff like that? Do you like hearing more information about your illness, or would you rather, someone speaks to your parent about it? What are some of your favorite things to do? What makes you happy? And even in this older one, it talks about like things like intubation. It talks about things like even funeral planning. How do you want to be remembered? What songs do you like? It's not for everyone. And often I share it with the parents first. I often don't leave it alone in the room. Sometimes I go through it and use it as like a guided discussion tool. But I think it's great. I had a young adult, really like an adolescent young adult, use it, and she planned her funeral down to the flowers that she wanted there. And it brought her so much peace, and it brought her family so much peace. So it also, I believe I have copies in Spanish. I'm not sure if they're in any other language, but they're really great. So I keep them stocked, and I would recommend you keep it nearby. Okay, a word on pediatric hospice. Okay, so we still have the Affordable Care Act, so I'm going to talk about it. So the 2010 Affordable Care Act has something called the Concurrent Care for Children requirement, and it's really important that you know about this. That state Medicaid is required to pay for both curative, life-prolonging treatment and hospice services for a patient under the age of 21 if they have a hospice qualifying diagnosis, right? So if prognosis is expected to be 6 months or less. But remember, prognostication is really difficult in pediatrics, so we often have a lot of wiggle room, and many of the hospices I work with will really accept kids with a prognosis more in the year or less because, again, it's just so hard to prognosticate. They can continue to get their chemotherapy, their RT, their other surgical things. They don't have to, sort of pivot away from disease-directed therapy to qualify for hospice. They can get it. They can get both at the same time. It's called concurrent care. And because most pediatricians don't know about concurrent care, hospice is really underutilized in the pediatric population. But I think now that more and more hospitals are offering pediatric palliative care services, we're utilizing our hospice services locally. Like I said, it only applies for children receiving Medicaid or CHIP. But I will say that private insurances often allow for a hospice carve out. And I've had success advocating for it in certain circumstances for children who may qualify for hospice and also want to pursue disease-directed therapy at the same time. So I'm able to get concurrent care. In some cases, it requires a peer-to-peer. It's not going to, probably unlikely to show up on the boards, but this definitely can. So keep this in mind. There's some state-by-state variation. I wouldn't sweat that. Okay. Board style question number 3. You are the palliative care physician responsible for the care of a 13-year-old child with severe neurologic injury after sustaining a severe motor vehicle accident 3 years ago. During your physical exam, you observed the child's facial grimacing, guarding behaviors, hypertonic muscle contractions. The child is nonverbal, bedbound, has limited mobility. Considering these exam findings, which of the following is the most appropriate next step? So this is a question of like sort of this one of the symptom clusters that you're going to see and potentially in children, which is these children with severe neurologic injury that have like this kind of spastic hypertonicity, non-specific pain. This is a cluster that you're going to see. So A, initiate a trial of high-dose opioid therapy for pain control. B, prescribe baclofen. C, increase the child's nutritional intake to alleviate symptoms. Or D, administer quetiapine to treat the patient's underlying delirium. And the answer here is to provide baclofen. This idea that like children with severe neurologic injury develop spasticity, it's to be expected, and we need to be proactive about treating the spasticity as a cause of the pain. Opioids are not necessarily off the table, but certainly we wouldn't try high-dose opioid therapy. In the beginning, we would try our non-opioid adjuvants first, as we would with any other patient. Other spasticity treatments that might pop up here, benzodiazepines like Valium, we use very frequently in children with severe neurologic injury and spasticity, botulinum toxin for sure, and clonidine. So just a word on neurologic impairment in children. You might come across a question about lower motor neuron conditions. The big one you might get tested on is SMA1, spinal muscular atrophy type 1, which is the most severe. There is a type 0. Those children do not survive to term. But if you have a child with an SMA1, these are children that typically die within the first year to years of life, often related to respiratory insufficiency. You might get questions about the muscular dystrophies or congenital myopathies. These children typically live to teens or young adulthood. And the questions that you might get are involving nutrition, respiratory support, medical technology. And again, it's a really personal question for these parents, whether or not they want to utilize these to prolong the length of the life of their child, and weighing that against, what does a quality of life look like for them. And then CNS impairment, you might get questions about like central nervous system problems like HIE, which is hypoxic ischemic encephalopathy from birth or during childhood, genetic or metabolic disorders, epilepsy, and there's a whole host of symptoms that come with this. Just be aware of some of these symptom clusters that you might come across. And children do become delirious. I don't think this past child in the question was necessarily delirious, but children become delirious just like adults, especially when they're in the ICU for a long period of time. So we have something called the CAPD score, the Cornell Assessment of Pediatric Delirium score. And that's actually a nationwide scale that's used, and anything above 9 is considered delirious in a child. Okay, I think this is our last board style question. The obstetrics team at your hospital has requested your support for a pregnant mother who's received a diagnosis of anencephaly, which is no brain development or limited brain development, at her 20-week anatomy scan. The OB has counseled that the baby will likely not survive beyond the first day of life. What is the next appropriate step? So this is a question of a case that I see I see these cases. A, recommend immediate induction of labor to minimize the emotional impact on the mother. An unlikely answer. B, encourage the mother to solely rely on the obstetric team for decisions regarding labor and delivery. C, advise the mother to wait until after delivery to discuss medical management of the baby. Or D, initiate a conversation with the mother about developing a comprehensive birth plan that addresses her values, wishes, and concerns. Okay, so this is a softball answer here, but clearly the idea that I'm trying to say is that we can provide something called prenatal or perinatal palliative care. It's a real thing. It may show up on your boards. And we, again, provide the principles of palliative care to these scenarios. But we're doing it with a little bit of a in special circumstances. So I just want to acknowledge that approximately 1/3 of in-hospital pediatric mortality occurs in the NICU. So a lot of my consults are coming from the NICU, and they can come from complications of prematurity, complications of delivery. So even if the pregnancy went, as expected, there could have been some sort of problem during the delivery, or an underlying condition or illness like the anencephaly that we had in the last case. And so for all of these, and I really would ask you to avoid terminology like incompatible with life or lethal malformation, because some of these children really do live for some time. And even if that life is 5 or 10 minutes, which I have parents who cherish those 5 or 10 minutes with their child, that is still life. So I would not use, incompatible with life. We talk about resuscitation and cardiac repair or palliation. Like, for example, our trisomy 13s and 18s. Back in the day, we used to say these were children that really weren't able to survive. Now, many centers are offering resuscitation and even cardiac repair for some of these children, acknowledging that they may not live very long, but if the goal is for these children to live even briefly and it aligns with families' goals and values, they will offer it. And also, interestingly, neonatal mortality is generally higher in males than females. I don't know why that is. I can't talk about what I saw on the boards, but I think this is very possible that it could show up on the boards. And then prenatal or perinatal palliative care, you want to consider a birth plan. Newborns feel pain, so you got to treat their symptoms. I have here a couple of examples of questions that we ask when we're creating a comprehensive birth plan. It's everything that you would use to kind of acknowledge the humanity of this child by maximizing their quality of their experience, the birth experience, and their sort of experience in this world, while also minimizing suffering. So I'm going to just leave this here, and you can go through some of these questions. But these are the things that we're asking in the setting of a birth plan. Oh, I had one more question. You are a pediatric palliative care physician involved in the care of a 7-year-old patient with pre-B-ALL, refractory to multiple lines of chemotherapy. The patient's parents are in disagreement about pursuing further chemotherapy. Her stepmother insists on pursuing further disease-directed chemotherapy, believing it's in her stepdaughter's best interest to offer a chance of remission, while her father argues for a less aggressive approach. What is the most appropriate approach in this situation? Okay, so conflicted parents, conflicting family members, you might get a question about this. And they have a couple of different things here about whether or not the parent is biologic or the mother's wishes or whatever. But go with your gut, right? Facilitate a family meeting to discuss the child's best interest and shared decision making. If you have conflict on the boards about family members, the answer is going to be hold a meeting and try to get everyone on the same page. That's always the first step. So ethical, I see that my time is getting shorter. Ethical issues in pediatrics. Children don't have competency, which is a legal term, but they may have capacity. And so children can provide assent and should engage in their care in an age-appropriate way. And we often include them in decision-making. Parents are the default surrogates, but there are examples of emancipated minors if they have financial independence, if they're married, if they're in the military, they become emancipated minors, and then they can make all their decisions themselves. And then there are certain examples of when information is confidential from their parents, such as pregnancy or receiving care for sexual health, even after death. So even if the child dies, because this is a palliative care exam, these remain confidential. You may get a question about the baby doe regulations. It sounds confusing, but it's really not. the bottom line is that like all children, infants, even under the age of 1, with life-threatening conditions are not required to undergo treatment. We can do goal concordant, comfort-oriented care for infants under the age of 1 if they have a life-threatening condition. And I think in the last slide, I'm just going to say that for adults, we typically use what's called the substantive judgment standard. For formally competent individuals, our surrogates make the best guess of what their family members would want in a certain situation. We don't use the standard in pediatrics. We use what's called the best interest standard because children are never have competency because they're not legally of age. So we always we use a different decision making with families. We always try to figure out what's in the best interest of the child. We don't say, what would Tommy have wanted if Tommy's like a 6-year-old? I'm going to skip this. So final advice here, children are not little adults. Rely on your principles of palliative care. Think about their developmental level. Remember your interdisciplinary team. We are trying to add life to the child's years, not simply years to the child's life. I have a bunch of references. I wish you guys good luck. I hope this was helpful. Feel free to email me if you have questions, if I'm allowed to give my email address, and that's really where I'll end it. And thank you for having me. And it looks like we have a couple minutes for questions.
Thank you so much for this excellent and really engaging talk, Dr. Salant. I know this is a topic that a lot of us who are adult-trained physicians get super nervous about for the boards, and I really appreciate that you made it so practical and engaging. A couple of questions in the Q&A for you. Sure. One is, I'm an adult palliative care doctor who is occasionally asked to care for children. Are there any high-yield resources that you'd recommend?
Yes. So there's a textbook that's actually really wonderful. It's called Interdisciplinary Pediatric Palliative Care. It's one of the editors is Joanne Wolf, who was the director of pediatric palliative care at Boston Children's. She's now at MGH. It's a really wonderful, comprehensive book that I would recommend. And then I would say that's just like the gold standard textbook. It's actually kind of small as far as textbooks go. I'm trying to think of other high yield resources. One other resource I would recommend is something called the Courageous Parents Network. So it's a website that's a nonprofit that's geared for parents about end of life and medical decision making, especially surrounding technology. But it's totally vetted, and they have resources in English and in Spanish, and and they have videos, and it's like good for the parents. And I would recommend that. I also learn a lot. They have a pathway on end of life, a pathway on neurologic illness. So I would say those two. That textbook is I keep it in my office. I refer to it all the time. Julie Hauer also has a book from Boston Children's about children living with neurologic illness. That's a really good one too.
That's fantastic. Thank you for those resources. One more question in the chat, a little bit different in focus. What do you suggest in situations where a parent is dying and doesn't want to be honest about it with a child?
Yeah, that is a really hard question and a fairly common occurrence, unfortunately, maybe not in quite that way, but this idea of wanting to protect their child from difficult information. My approach, and this would also potentially be the approach on the board exam, but my approach would be to really try to understand why that is. Okay, what is the rationale? What is the parent thinking? I would sort of use as an opportunity to talk about hopes, concerns, like we would, what are we hoping to achieve by not sharing this information? Because I bet that some of those fears that they're worried about, we can actually address in a really beautiful and age-appropriate way. We can share some of this information about talking to children, that they're able to, weather it and handle it, and actually it can decrease their anxiety because they usually know something's wrong and they can sense it. So my approach would be, while you can't share information to a child without their parents' permission, so I would honor that if that were a hard stop. I would explore why that is. I also see that families sometimes don't want their children to know about their own diagnosis. Like, don't tell Jimmy that he has cancer. We use the same approach to talk about why that is, and try to allay some of those fears.
That makes a lot of sense. Thank you so much for joining us this morning. We really appreciate it.
Thank you so much for having me. Good luck, everyone.